Hello and welcome to the Completed Life Initiative's latest symposium, Last Hellos, New Models in Global End-of-Life Care. This symposium asks the question, how do we navigate one of life's most transformative experiences, our dying?
Drawing inspiration from Australian poet Les Murray's observation that these kind of questions summon last hellos. Today's Global Symposium welcomes speakers from Australia to Belgium, the United States to Rwanda, as we explore new models in end-of-life and palliative care.
From the origin of what it means to be palliative in the context of Aboriginal communities, to the scientific inquiry into the effect of placebos, from research into personal narratives of end-of-life visions, to expanding eligibility considerations for medical aid in dying. This two-day symposium invites you to contemplate one of life's most powerful transformative experiences.
Your presence in this virtual space means a lot to us, and we are grateful for you tuning in today. Be sure to stay till the end of this presentation, as there will be an opportunity for you to join a Completed Life Initiative team member and your fellow symposium attendees at our virtual event cafe. Thanks for joining.
Good morning and welcome, everyone. My name is David Hoffman, and I am happy to have you join Dr. Shannon Mazur and I for a symposium on examining stages of end-of-life consciousness, a look at palliative sedation. Let me introduce myself first. I am, in turns, a hospital lawyer and ethics and compliance officer. I also serve as the ethics consultant for a very large home hospice organization, and I teach bioethics at Columbia University. You should also know that I am a member of the board of directors and an officer of the Completed Life Initiative, so I have an affiliation that obviously influences my views on a lot of issues about end-of-life care. I am thrilled to be joined this morning by Shannon Mazur, who is a psychiatrist at Yale University. And Shannon, introduce yourself and talk a little bit about the work you do.
Great. Thank you, Dr. Hoffman. As you mentioned, my name's Shannon Mazur, and I got into this business about 20 years ago when I was an undergraduate and got into a medical ethics course and just started to realize how much how needed it was to kind of learn more about the complexities and challenges within our medical system. So I ended up working at Loyola University of Chicago, getting a master's degree, and then taught in the field for quite a few years before I went off to medical school. But during that time, I realized how important hospice care was, and so had been working in a hospice organization with the kind of this mission of no one dies alone, and providing compassionate companionship to patients in the last few hours of their life. So kind of was a springboard for the rest of my career, which led me at Midwestern University for my medical degree, followed by a residency in psychiatry at UMass Bay State in Massachusetts, and then went on to Yale to do my fellowship and consultation liaison psychiatry, which brings me to where I am now. I'm the lead physician for the Yale Psycho-Oncology program at the Smilow Cancer Hospital in New Haven, and I'm an active member and secretary of the Adult Ethics Committee here at the hospital, and I am the chair of the Academy of Consultation Liaison Bioethics SIG. So spend most of my time working with cancer patients and helping with various aspects at end of life.
Well, that's terrific, and it's going to make this discussion very interesting. I have to say, you are the first psychiatrist with a deep investment in end-of-life care and bioethics that I've had the pleasure of doing a webinar with. So I think we're going to have a really interesting discussion. Let's start off with some basic definitions, because I think it's important for our audience to understand that the term palliative sedation has different meanings in different contexts. So I start out with a definition of palliative sedation as a broad umbrella term that can describe everything from a patient who needs sedation for the duration of some curative treatment because they're experiencing some acute, extreme pain, and they need to be relieved of that pain while their medication treatment takes effect. Disseminated infection in the extremities, for example, and the need for antibiotics to have a chance to knock down the infection. From there, all the way to what we refer to as terminal sedation, including sometimes terminal sedation to unconsciousness at the end of life, and everything in between. So all of the forms of analgesia and anesthetic management that would relieve a patient's discomfort, suffering, physical, existential, combination of both within those two parameters. How does that fit for you, Shannon? What would you add to that definition?
I think that was a really good summary. It has, fact that it's acceptable in all 50 states. It's widely used mostly in the hospital system, although can be, as I think we'll discuss later, and used in other settings such as the home and inpatient hospice care, and is we've had anesthesia and this around since the 1800s, but really not till around the 1990s when there started being kind of a formal practice in the literature and more research, and then has kind of picked up over the last 30 years. So that kind of summarizes most of it.
Yeah, I should have added as well that what we're talking about here is one form of care, and we're discussing it in the context of end-of-life care, but that makes it just one of the many choices available to patients with regard to end-of-life care, and that can include VSED, voluntarily stopping eating and drinking, VSED by advance directive, medical aid in dying, which goes by many names, physician-assisted death, and different terms in different countries. But this is a choice, and I think everyone needs to understand that there isn't one best or one appropriate form of care for every single patient. And that's why at the Completed Life Initiative, we really stress the notion that patients should be aware of and have access to a full range of choices at the end of life to deal with their particular situation. And we're going to get into that in some detail. So you had a very interesting experience at Yale, creating a system-wide protocol for the use of palliative sedation at all of the Yale-affiliated hospitals and other healthcare institutions. Tell us about that and tell us how it got started.
Yeah, it actually came to be after a very important and if you will, kind of life-changing case for me that opened up my eyes to the need for having communication about the available options to patients, including palliative sedation. So I'd like to tell you about a patient of mine. Her name was Cindy. She had given me permission to use her name and was really became very invested in her care. So she's a 65-year-old female. She was married, had an adult son, a dog. She was a very social person, worked in real estate, very active, really unremarkable past medical history, somebody who'd kind of consistently gone to her doctor's appointments and kept up with her health. And then COVID hit, and as we know, the medical system got hit really hard there. And so her annual mammogram got pushed back quite a bit. Even she was having some symptoms, but wasn't able to get in. So almost 2 years after she was first having symptoms, finally had her mammogram in May of 2021, and was found at that time that she had already had invasive lobar carcinoma of the breast that had gone into her chest wall, into her lymph nodes. And there was thought that there wasn't going to, couldn't be curative. There was no surgical resection because it had gone into the chest wall. And so for the next few months, she was meeting with social work, palliative care, oncology. There's no concerns about her psychiatric health or any suicidal ideation, anything like that, but had expressed that she had seen several family members who had gone through cancer treatments, and their experience, they had kind of suffered, and her mother-in-law had said to her as she was passing that she regretted doing chemotherapy. So this was something that the patient had already formed a lot of thoughts on, and had really had her own life experiences. So when it came to her decision, hearing that it was not curable, that surgery wasn't an option, she had chose not to go forward with chemotherapy or to go down that path, but to try to get as much quality of life as she could over quantity. And so it stayed that way for a few months until November, when she started to have pretty active bleeding out of her rectum, a lot of GI pain, and had been found that she now had a mass in her esophagus and stomach, and now had it had spread throughout her GI tract. So she kind of kept the course until January, when she had a small bowel obstruction, meaning that she couldn't have any food, couldn't stay down because it couldn't get through, and had uncontrollable vomiting, nausea for over 24 hours, which got her back in the hospital. At this point, this is when I actually got involved, and when I came to as a psychiatry consult, and when I came to meet with her, the consult wasn't what I was expecting. It was actually because she was having some anxiety, because she realized that she wasn't going to be able to swallow pills anymore because she could not keep anything down. And she had strong beliefs that she should be able to choose how the last moments of her life would occur, and had spent some time researching on the internet how she might end her own life. She had a full psychiatric evaluation, was very clear that she was not depressed, did not want to die, but rather did not want to end up suffering at the end of her life. Had got collateral from her husband and several other people who all agreed that this was a lifelong kind of viewpoints that she had, and that they did not think she was actively depressed, and thinking that psychiatric hospitalization would, in her husband's words, would kill her, and that did not seem appropriate. So you can imagine, we got a whole group of people together, legal, ethics, palliative care, social work, hospice organizations, primary team, oncology, the directors of psychiatry. Everybody got involved in this case at that point, just because of her pretty clear stated wish to go home and use her own medications to try to end her life, being in a state that doesn't offer medical aid in dying. We came to a consensus after all of this, and after a lot of support and discussions and collaboration, that she was going to be allowed to go home with hospice care. She was going to have follow-up with outpatient psychiatry within a week of discharge, which was me, and that her husband was going to remove and lock up any large quantity of pills at that point, and that hospice was going to be very involved to try to help with her care at home. She did not end up showing up to her follow-up appointment, but when I called to speak with husband and her and the hospice organization, everybody had kind of agreed hospice was meeting her needs, and that she was doing well under their care, and they had encapsulated her at that point. So unfortunately, about 5 weeks after that, she did come in after trying to take her own life, had consumed large amounts of medication, and was significantly delirious when she came in. She survived actually pretty much unscathed. It's one of those that doesn't really add up with the amount of medications, because I think she must have had some vomiting or whatnot, and ended up after about 2 weeks, was pretty serious at first, but after 2 weeks was completely medically cleared. But here we were, no hospice organization would take her because she was too risky to go home. Going to an inpatient psychiatric hospital wasn't appropriate, and she wasn't, so she was kind of trapped in the hospital in a way that she had always hoped that she would never be. And so for the next 11 weeks, I met with her on almost a daily basis. At times, she would go almost a week without being able to eat or drink because of nausea and vomiting and the small bowel obstructions. And then there would be times where it would calm down, and she would actually be okay and be able to take very small quantities in for a couple of days. And so after this 11 weeks, we spent a lot of time talking about end of life and what her anxieties were, and how she still had this anxiety of the fear of the end of her life. And it was along that time that we were able to talk in extensive depth about palliative sedation. And for her, this was the first time that she was able to have some peace about the end of her life, knowing I'm not going to be able to go to Vermont or New Jersey to get medical aid in dying at this point. I'm not traveling across state lines. I can't go. I'm not going to try that at home again. I'm not, really feeling limited, but knowing there was this option that was acceptable in 50 states and in our hospital and around, that could have a way that for her felt safe, but also kind of this ability to know she wasn't going to suffer, that she could undergo palliative sedation if it was appropriate at that time. And so we really kind of changed our discussion and our viewpoints with her, and we're able to get her to discharge home because of the fact that now, having known that and knowing that she could come back into the hospital to receive that was something that helped her be able to discharge. Unfortunately, she did end up going to another hospital and did not end up getting palliative sedation, but ended up having quite a hard road at the end of life, not getting her pain meds met, her pain needs met. And I was, from that moment, kind of vowed, this is something that should be a part of every hospital system, that is known. And here at Yale, we did not have a policy in place either. It occurred, but there was no systematic policy for it. And so she was really the springboard to have a committee formed, and that was a multidisciplinary group, and be able to have it initiated at our Yale hospital system and our 5 or 6 other hospitals within the system as a policy that was system-wide.
Fascinating, heartbreaking case, and one that raises so many questions. It is really emblematic of what the Completed Life Initiative exists for, which is the notion that every patient should have control over the circumstances of their passing, and that they should have a death that is, as I like to say, safe, certain, and painless. And it seems like Cindy is a prime example of how the system can fail to really serve our patients when we're not prepared for this. The thing that I'm most curious about is how you, as a psychiatrist, were brought into her care in the first place. What was the actual stated reason for the psych consult?
Yeah, we say in psychiatry that the consult's not always the consult, right? What's the real reason? So it had said for mental health support at end of life was, I think, what it was. But she had started to, when I met with her in January, she had expressed to I think the social worker, a couple other people, about how she had these viewpoints on end of life, and that she had been saving up pills. And so it was, for me, it was a suicide assessment, basically, and the kind of legal and ramifications if we were to discharge a patient home, knowing that she had expressed that she was saving up pills to end her life. And so it was really a psychiatric evaluation for depression, a treatable cause, something that, and that ultimately for me was the reason why psychiatric hospitalization was not appropriate in my mind, because it needs to be a treatable a disease, or something that going inpatient was going to change if we were going to give her medication or therapy or whatnot. And she was not depressed. She wanted to live. She was very clear she had capacity. She was cognitively intact. She was not delirious. I had collateral from multiple different people. These were lifelong expressed values for her. And so it was initially for suicide evaluation was why psychiatry was involved.
So let me ask you, when she actually did try to ingest that medication that she had saved up in order to end her life, did you consider that an instance of self-managed medical aid in dying, or did you view that as a suicide attempt?
No, she had written a note stating, very clear that this was something that she had been planning, and had actually said, if I had lived in a state that had medical aid in dying, I would have pursued that. And stating that she had wished that she had access to the same options that people, just because of their location, had differently than her. I had spoke to her husband about that time, asking if he noted any change in her personality, more tearful, confused, depressed, sad, things like that. He had not noticed anything. And the reason why it happened at that point was because prior to that, she had about 2 days of uncontrollable nausea and vomiting where she couldn't keep anything down. And so for her, when she had this break where she had gone 6 or 12 hours where she finally had stopped vomiting, she thought, well, this is my moment when I can do this, because if I wait too much longer, I'm worried I won't be able to do it. And so that was she was very methodical in why she chose that moment, even though she did end up living a couple months after that. But it was because it was so uncertain that how much the tumors had spread.
Yeah, so our audience should understand that that phenomenon is what we describe as the window of opportunity for intervention, and patients often seek intervention because they don't want the window to close. And that's especially true in the United States because, of course, all medical aid in dying and other medication-based interventions need to be done through the GI tract, unlike Canada and most of the rest of the world. The US, for legal reasons and frankly for political reasons, doesn't allow intravenous administration of medication to aid in dying, something that we clearly need to do more work on. So how did Cindy's case turn into the work group to form a policy on palliative sedation? And what were the opinions that were initially expressed about the role of palliative sedation in end-of-life care?
Great question. Yeah. So when I was meeting with her during that 11 weeks, I had, through my own research and my time in hospice care before, I had my own knowledge and background on palliative sedation. And I knew that there had been some cases that I had been involved in on the ethics committee where palliative sedation had occurred with a patient. But every single time it got brought up, it was always in the midst of moral distress of the healthcare workers, and not really knowing who to turn to, who has to get approval. Do we need the chief medical officer involved? How many attendings need to sign off? And it just seemed inevitably every single time we went through this that it was just this big emotional roller coaster. And so when I started discussing it with Cindy, at the moment it was almost uncertain, would it be in the midst of her uncontrollable nausea and vomiting as a symptom, or this just very strong anxiety around her death, that she did not want to lose that control. And so thinking of kind of that from the more existential, however, she had this very clear physical needs with the nausea and vomiting. And so I had reached out to palliative care during that 11-week time to get them involved and to discuss this and saying, is this something, I want to make sure that if the time comes, because we didn't know at any moment, we thought it could be the last time she stopped eating and drinking, and that we were going to go down that path. I don't think any of us thought 11 weeks were going to go by. And so I've tried to get them involved early, and we realized, why are we still recreating this wheel every single time? How is it at this point? It was 2023 when we were trying to invent this, but actually probably 2022. And so it took over a year of hard work and dedication from a wide variety of people from literally every aspect of the hospital. There was kind of one representative that joined this work group to be able to give their input, from the chaplain to nursing to social work to psychiatry, legal, hospital administration, and really form this group to say what is acceptable, what can be standard process, what from a medication standpoint, how do we move forward from a communication and documentation. And so really got to see the ins and outs of all of the hospital policy side, but it was also wonderful to see everybody coming together, wanting to make sure that the experience could be, as streamlined and less anxiety provoking or emotionally disturbing for not only the patient and their family, but also the providers and everyone involved in the care of the patient. And so we were able to get the hospital policy up to, and I'm happy to say that as of March of this year, it finally is in place. So, and throughout all of the hospital systems, just so there can be this kind of clear, rigorous, streamlined process to have whenever it occurs, and doesn't need to bring up unnecessary questions or deliberation, but can be easily accessible.
Right. We shouldn't be reinventing the wheel each time a patient needs this kind of care. So I'm really interested to discuss the policy itself, but first I'm perhaps most curious about the first meeting. What were the range of attitudes about a hospital, especially a large, prestigious academic medical center like Yale, having a meeting to discuss palliative sedation as an end-of-life intervention?
I think overall, it was accepted. It was people were kind of excited about being able to have something in place to remove some of the concern. However, it was some of the minute details that became kind of I don't want to say problematic, but that was where we ended up in that first meeting having these kind of long side conversations about things such as, for instance, one of our hospitals is St. Raphael's campus that came from a Catholic religious order and then had been bought over by Yale, but follows within some of their practices, and there still is within when we had kind of signed in with them that there was going to be some kind of honoring of some of the traditions that had been within that hospital. Now, palliative sedation it does take place at that hospital. It already had been, and it still is, and there are ways that it is in line with their teachings and policy. But I think it was very important to them that the wording, kind of went with what they were that made them feel comfortable with having that go into practice.
Right. So our audience should understand that this issue of secular and religiously sponsored healthcare organizations is a significant issue across the country. And what we're talking about here are the ethical and religious directives of the Conference of Catholic Bishops of the United States. And this is a very important part of the healthcare discussion, specifically because Catholic-sponsored healthcare institutions are such a big part of our healthcare delivery system. So where did it go from your first meeting and the notion that this ought to be something that's better understood?
So then there became, we realized that we weren't the first institution creating this sort of a policy. So we had reached out and had gotten some information from several other kind of ethics teams at other hospitals in the area and throughout the country, and we're kind of comparing their policies to feel what would our policy encompass, and making sure that we were putting together something that felt appropriate within our hospital system. And so each party, if you will, stakeholder was able to give their input on what would nursing care look like. Is a spiritual care chaplain automatically involved, or is that something that should be decided? Is ethics always going to be consulted for these decisions? Who is in charge of the medications? Is that anesthesia? Is that palliative care? Is that the primary team that's caring for the patient? And so all of those little differing points were determined. So again, so that this discussion did not need to be happening in the moment where it was filled with emotion and family, and also where time is valuable. And so we were able to have everybody kind of weigh in and give their opinions, and based on research and clinical documentations that had come before us that had shown kind of what was best. So for us, it really does come from our palliative care team. So palliative care leads the way with the medication distinction of what medications, how much the dosage is, and has to be an integral part to the palliative sedation process. And so at our hospital, they take the lead.
And so let me ask you, in those initial meetings focused on developing this policy, was there an understanding, a consensus about what was meant by the term palliative sedation? Did everyone think of this as palliative sedation to unconsciousness? Was the notion of terminal sedation as a form of palliative sedation part of that discussion?
Absolutely, yes. We did determine, we did clarify and had our document actually starts with a terminology section and a definition section, so that we could be clear within our policy what we are defining within that. And there was quite a bit of debate within that, trying to determine what qualifies. And again, kind of turning to the research, we see, I mean, there is no clear-cut line that says, you know, if you are vomiting for more than 3 days, that's when this happens. Or, you know, if you're at this milligram of pain medication, we're going to call that uncontrollable. That's not how it works, because every patient is different and every situation is different. And so there were some things that were easy to, that everybody was kind of agreeable upon, meaning that the patient had to be terminal, and we use the definition of terminal as 6 months, expected less than 6 months to live. But then you get into that gray area of, well, and end of life. And so is that hours, weeks? How do we know? And so there is some gray area within that, but absolutely needed to be terminal. And the thought was that it was at nearing the end of life. And then to touch on kind of what symptoms or what would qualify and what wouldn't qualify, we had quite a bit of debate about the thought of kind of existential suffering as a sole notion. And when we speak of existential suffering, we mean kind of that loss of demoralization and hopelessness, fear, death fear, distress, hardship due to kind of the loss of meaning or purpose in one's life. And ultimately, as we were just trying to get this first policy off the ground, it was thought that at this point, as a sole distinction, meaning that there was no treatable, wasn't a physical symptom such as nausea, vomiting, pain, delirium, that was rather just from this kind of existential emotional standpoint, that we would exclude that as a sole criteria. And so that certainly could be a part of a patient's presentation. And if they had that, that wasn't going to mean that they couldn't have palliative sedation, but if that was the only untreatable symptom, that distress, that would not qualify them. I do foresee down the future that our definition within our system will expand to encompass that, as many other hospital systems have, and is widely accepted in many other countries. But that again is a much more difficult conversation because of the fact that it's not quantifiable. We can't have a test that tells us how much emotional distress a patient is in.
No, absolutely. So let's reflect this part of our discussion back to Cindy's case. Cindy was clearly terminally ill every day that she was in your care, both inpatient and when she was discharged home. She was experiencing physical symptoms, for her mostly the nausea and vomiting, intermittently, although I take it with great frequency, correct?
Absolutely, yeah. It was
Yeah.
It was more than not. So she might have 5 days of extreme abdominal pain, nausea, vomiting, and then relief for 2 or 3 days. So it was the bad days. There was a period where that might have flip-flopped, but for the most part, it was the opposite.
More bad days than good days.
Yep.
So should we understand the policy that you crafted, which I think we need to all be clear was, your institution's first step toward defining what was obviously appropriate, with other questions clearly deferred for another day. Would Cindy have been eligible, do you think, under your policy if she said on a couple of her good days, this roller coaster ride is more than I can handle. I don't want to have to go through another 5 days of continual vomiting. Please put me to sleep for the last time. How would your policy have dealt with Cindy under those circumstances?
Yeah, that's a really good question, and one that I've asked myself many times. It's so hard because she would come back from it because of the fact that she gave herself gut rest, right? So there's kind of two ways that you treat the small bowel obstruction. One is your NG tube to suction everything out and give the bowel rest. The other is to just stop eating and drinking and see if that's enough to kind of calm things down, that things can start to pass again. And inevitably, once she started feeling well, she had such a, as I think we all do, connection to, wanting to drink something or wanting to eat something. And so when she had those little bits, she was getting enough nutrition in her in the good days that she was kind of sustaining her life, and that she would rest the bowel and it would kind of reverse itself. And then she would just kept going through the cycle over and over again. And so it's hard to say, because we weren't certain at what point it was going to be that it couldn't turn that it wouldn't relieve itself. And I think
Mm-hmm.
at that point, if she was never able, if it got to the point where it didn't, her gut didn't relax enough to the point where she was able to swallow and digest and excrete, food and substances, that would have qualified, that the nausea and vomiting that had not stopped, and that she was not able to have any sort of nutrition to the point that she started to, I would imagine, become delirious or too weak or not able to,
Mm-hmm.
it's starting to affect her ability to respirations, her other organ systems were shutting down. I think she would have been appropriate. And that was what we had discussed, that was what gave her the confidence and made her feel comfortable to finally be able to have kind of ongoing discussions about going home, with the notion of, if it gets to that point and it is not turning around, I can come back into the hospital. And if they see that this is happening, that I can have palliative sedation. And so so ultimately, yes, I do think she would have qualified. And I think that when that time came, that our hospital could have given her that support.
So let's do a little thought experiment around a variation of Cindy. If Cindy had a full bowel obstruction, and if it never relieved because the tumor had grown to the point where there was just no patency under any circumstance, and she was experiencing what is the inevitable abdominal distress, perhaps in varying degrees from moment to moment, what is your thought as a psychiatrist involved in the ethics of end-of-life care about palliative sedation in conjunction with her decision to not accept any sort of artificial nutrition and hydration, obviously not able to ingest anything orally? Would you be comfortable considering the combination of palliative sedation to unconsciousness and what is de facto VSED?
Yeah, I was just going to say, and just to clarify for those who don't know, V said voluntary stopping of eating and drinking. And that was something that I had discussed with Cindy at different points too, kind of even earlier on when we were reviewing options. And not that I was saying, hey, I think you should stop eating and drinking and you'll die that way. But rather that we were kind of exploring, and one of her concerns that she kept bringing up was, well, what's going to happen if I can't eat or drink? I mean, I'm going to die, right? Like that will eventually happen. And so I actually explained to her kind of the biological process that goes with voluntary stopping of eating and drinking, and the fact that people can reach this point of comfort where they lose that hunger sensation and the kind of some of the thoughts that go with it, and that this is actually a practice that some patients engage in, and that is, kind of ethically and legally supported and throughout the country and the hospital systems. And so I think that that for her, when she started to feel better, she wanted to eat and drink. So she couldn't wrap her head around taking her life in that method. For her, it also was, well, how many days is that going to take? So I'm going to sit there and suffer in that way. Whereas, can I just take these pills, or can I just be, can I just not experience it through unconsciousness? And so there was some discussion around that for her. But for her, having the thought of having her not be the one that had to think about it, that the team would be taking over, kind of keeping her comfortable in the unconsciousness, that was more desirable for her.
And let's just pause to observe the phrase you used, taking her life, that she would be taking her life. And so we focus a lot of attention on that sort of narrative medicine aspect of how we frame and phrase and describe options that patients have available to them at the end of life, and the need that I think we all have, those of us who do this work, to distinguish between the notion of taking one's life, thought of or often described as suicide, versus taking steps to relieve symptoms, pain, suffering, knowing that that will result in the end of your life, that whole double effect notion. This is something that we need to be careful about and conscious of in our discussion with patients. And I think it's useful for our audience to understand that this is a challenge for you and for me and for everyone who does this work. And that's why these discussions are so important.
It reminds me of a conversation I had had with her once, that she was so upset thinking that her death certificate was going to read suicide, and so that she did not want that to be there. But and this was when I was talking to her before she had made the attempt to kind of during that first hospitalization that I was with her. And she said, because I was asking her, questions from every angle to really, and I had asked her about that aspect, not specifically, well, what do you think is going to say on your death certificate, but, do you have life insurance policies? Do you have these? What are, because she had mentioned things such as, I've started to kind of give away some of my jewelry to my son that he could give to his future wife. And these kind of comments that this wasn't a rush decision, but this was actually something that she's reconciling with her life. And one of the things that was brought up to her in that moment was the fact that she wasn't going to have, that her life insurance was going to be, there was a question or concern if she would get that, her husband and her son would get that, and that, she didn't like the stigma that on her death certificate it would read suicide. So language was very important in her thought process and discussion of all of this end of life care for her.
Interesting. And I want to talk some more about where we go from where the Yale policy and other policies like those leave us. But I want to reflect just for another couple of minutes on the conversations you had as a psychiatrist with Cindy after her attempt to end her suffering by ending her life with the self-administered medication. How did that go?
Well, as kind of a consult psychiatrist, we're normally pulled in many different directions, so we don't always have the time to do kind of what we would call bedside therapy, if you will. And but that's kind of what ended up happening, in the sense that we would have these long conversations talking about different aspects of her life and what had been helped her grow her values, her own narrative, her own life story to get to the point where she was at, and really thinking about her relation with her husband and her adult son, and who was engaged, and her desire to want to be at their wedding, and kind of this feeling of being torn in so many directions. But ultimately what she kept coming back to and sharing with me is the fact that the cancer was what was driving this. It was not that she was making this decision. It was that the cancer was making this decision. The cancer was going to kill her. That nobody was debating that, and that was very clear. And it was clear that she was also somebody who believed in medicine and who had gone to her medical appointments. And she had said, if it was, stage 1 or 2, I would have had the surgery. I would have had a mastectomy. I would have had whatever it was. But the fact that it already spread so far, and that it was only going to be palliative, and that palliative chemotherapy was the only option. It just was not acceptable to her at that point because of her life story. And so it really was getting to know her as the person for the 65 years leading up to that point, that helped inform kind of her thoughts around it, and my ability to sit with her and really not seeing, a treatable depression or a treatable anxiety or panic attacks or things that were, or psychosis, delusional thoughts or altered thought process. That was not present. She was very clear and cognitively intact. And so, that a lot of our discussions ended up just being kind of long conversations about things, but also would always try to kind of bring back to, well, where does that leave us now? 1 weekend, 2 weeks, 3, 4, 5, 6, 7, 8, 9, weeks into the hospitalization. And she did her best to try to live in the moment, even in the hospital. She decorated her room with lights and flowers, and really had made a very stale medical room, because we don't have kind of a end of life care at our hospital. So it was just a standard medical room on a very busy floor, but had made it her own because we weren't sure if she would ever leave that hospital. And she really wanted to have some control over and be able to determine what she was going to be surrounded by. And so for her, bringing in plants or flowers and her husband bringing in different aspects made that hospital room more of a room for her than just a hospital room.
Which really brings us right to the next topic I feel like we have to explore, which is why do these patients wind up in the hospital? Because the conversation you recounted about her taking some comfort in knowing that if it got so bad at home that she couldn't handle it, that going back to the hospital for palliative sedation, be it to unconsciousness or otherwise, and whether it was explicitly understood to be terminal sedation, that is with the understanding that she was never going to wake up again, as a hospital-based procedure. That's very interesting to me. I do a good deal of work with long-term care facilities, and I advise a very large home hospice program here in New York City. And we deal with, when should a patient be able to die at home, and who really wants to die in the hospital. I know of very few patients who fall into that category, usually because of a lack of any support system. And it sounds like Cindy had a really quite excellent support system. So I'm thinking part of our discussion going forward needs to be about making these kinds of interventions, all of the different flavors of palliative sedation that we've been talking about, available to patients at home. We're spending an enormous amount of time in the hospital world talking about the notion of hospital at home, using all of the remote monitoring and remote therapy interventions to enable patients, in particular patients at the end of life, to avoid having to go back to the hospital for things that could be done in the home. And it's a much larger discussion, obviously, whether home palliative sedation, including home palliative sedation to unconsciousness, is a logistical possibility. It's a discussion we'll have to have at another day and bring in some of our palliative care colleagues and anesthesia colleagues. But the notion that it ought to at least be something that we're talking about, I think of as a moral imperative for us who are doing this work. We've been talking now for decades about end-of-life care as a continuum. And I would like to see the discussion of the notion of hospital at home as extending to ending life care, that is, interventions outside of the hospital that will end a patient's suffering by bringing about their end of life in a very predictable manner. I would like to see that as part of the discussion going forward. Do you see that as part of the potential discussion at hospitals?
Yeah, absolutely. And I'm so glad you brought that point up, because it is occurring. There is options for palliative sedation currently in the US at home, but it is so sparse and few and far between. And certainly none of the hospice organizations that that we're connected with here in my area in Connecticut do it or are familiar with it. It does seem like it's coming. New York happens to, New York and New York City happen to be kind of more able or have more experience with it. I think there are some other ones, but we actually can learn a lot, I think, from our colleagues overseas, where they're much more familiar with it, and it does occur, and they're kind of more accepting or have a greater practice of some of these end-of-life care options. And so I agree. I think that we need to be, if it's something that's occurring some places, we should be expanding our knowledge and seeing how we can make that a part of being offered to other people. I think that was one thing Cindy kept saying is, I feel like I'm being punished because I live in this state. Why is it that, and she was, mentioned she was in real estate. She loved her house. She'd lived in it for many years. She said, I don't want to pack up and move somewhere else. I know I could go to Vermont. I don't want to do that. And this is my home. Why do I have to leave my home? And just because somebody's in a different state, they don't have to. And so I think expanding these our knowledge to be able to have a better understanding of how people can do it within their own home with the assistance of hospice organizations, and whether it be palliative care or just the hospice organization, and who would assist with that, what would that look like, how do we do it? But it is occurring, and it should be something that we can educate and continue to research and find ways that it can be more streamlined and open to everyone.
Final question about Cindy. I just want to clarify this because I think it's a really important point. If Cindy had been a lifelong resident of Vermont or New Jersey or any of the other 11 jurisdictions that permit medical aid in dying, would that have been her choice, do you think?
Yes, 100%. She had made that very clear. And she had actually looked into it and looked about. Vermont and New Jersey are the two closest to us, in Connecticut here, but she had looked into going to Vermont, and it for her having to move was not acceptable. But she said if it were something that had been available here in Connecticut, and she actually had wrote a letter kind of to the state of Connecticut, to whom it may concern, kind of explaining her case and saying, I'm a voice here of somebody who wants to say this is something that should be available here in Connecticut. And what's very interesting to me, and I think is important to point out too, is that her husband was of over 40 years, was very supportive of her, but had differing opinions. He personally would not go forward with medical aid in dying if it were him in his own life, in his own situation. But yet he wanted to respect her wishes and her desire. And again, it had been this lifelong discussion that she'd had that as it had come up, in the news and of other discussions. And so even within one own's family unit, having differing opinions, but finding that way that he was still able to kind of support her and be there for her. He wasn't going to give her the pills, and he didn't want to, be a part of it necessarily, but he didn't want her to be alone. He didn't want her to feel that she had to do this on her own, and that was for him, he was kind of looking to me like, where's the medical system? Where are we to be able to help support her in this? And turning to me, him saying, I'm not a doctor, and I personally, this isn't something I would go forward with. I see why she chooses this. I can respect her values and her opinion, but this isn't necessarily my opinion. But so then who do I turn to? So he would kind of turn to me in this way, looking for the support and finding that unfortunately we have a long way to go within our medical system, not just with that, but thinking about kind of a system where nobody could accept her into their care, and she was, for lack of better words, kind of trapped in the hospital, that there was no appropriate place to place her.
So final thought, where do we go from here in terms of training clinicians and educating the public? This webinar is obviously a first step. What else do you imagine would be useful?
Yeah, I think that in palliative care field, it's very widely known, and people understand it. I don't have to have this conversation with any of my palliative care colleagues, and I think even within psychiatry, we're familiar with it, at least in the psycho-oncology field, I should say. But so many other providers within the hospital still aren't aware that this is an option, even within Yale. And so I think having education within our hospital systems, not just Yale, but all hospital systems, and making this aware, making hospital providers aware that this is an option that can be offered as an alternative when exploring end-of-life care, and having really understanding that there should be protocols set up at all hospitals, because there was no doubt in my mind how big of a role the moral distress of the healthcare providers was playing to every time when one of these cases would be brought up, because the nurses were questioning if they were doing something wrong. The providers didn't know who should, if the patient wasn't able to be making the decision. It goes to the family members it can be a decision that is made by the patient's healthcare proxy or family member. It does not, and so that brought distress. Well, how do we know this is what the patient wants? Is this just the family trying to, change the course of their life, whatnot? And so really having set protocols so that we can help this process go forward, and helping our ability to communicate this option to patients and families. And when I say that, just even in what I was just saying, kind of helping them understand in non-medical terms, the fact that we have shown that palliative sedation to unconsciousness, or palliative sedation, does not actually speed up the end of life. That when we look at the data, that it actually ends up being the same determination at the end of life. It is not thought that this is going to speed up the process and that it is going to be what ultimately kills them, but rather that it is just that they're going to be unconscious while that natural process is occurring at the end of life there.
Well, I think what has to come next at minimum is we need to roll out, you and your colleagues and people from other disciplines, to give grand rounds at every hospital in the country, so that at least doctors are aware that this is something that they ought to be learning about. I can't thank you enough for giving us generously of your time. This has been enormously helpful. And I've learned a lot about where psychiatry fits in the end of life. So thank you. And thank you all in our audience. I hope we see you at future programs. Thank you, Shannon.
Thank you.